Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Asad Qayyum, presently working as an ENT specialist at Maroof International Hospital, Islamabad. Today's topic, fungal sinusitis, is very interesting but a bit confusing. I have tried to make it simple in this presentation so that it is easily understandable by our students. Now, this presentation will consist of two parts. Number one, key points, which I'm going to read it to you. And in the second part, we will apply these key points to a tabulated form so that we can understand the different types in a compare and contrast model. Point number one, fungal infection of the nose and sinuses can occur both in immunocompetent as well as immunocompromised individuals. Point number two, what are the different types? Two main types, non-invasive and invasive type. What is the difference between them? In the non-invasive form, the disease is limited to the nose and sinuses, while in case of the invasive form, the disease extends towards the eyes and the brain. Prevalence. The non-invasive form can infect immunocompetent individuals, while invasive form infects the immunocompromised individuals. Now, coming towards the subtypes of these two main types. In the non-invasive types, there are two main subtypes. One is allergic fungal sinusitis known as AFS, and number two, fungus ball known as mycetoma. Coming towards the subtypes of invasive types, it has got number one, acute fulminant type, which is the most aggressive one, chronic invasive, and thirdly, chronic granulomatous. What are the pathogens involved? Aspergillus niger. Niger means black. That variety causes mycetoma and a type 1 allergic reaction in case of allergic fungal sinusitis. In case of invasive type, the acute fulminant subtype is caused by mucorales and Aspergillus fumigatus, while chronic invasive form is caused by Aspergillus fumigatus. These two varieties are caused by Aspergillus fumigatus subtype in case of the invasive type of sinusitis. Aspergillus flavus. Flavus means yellow. This type causes granulomatous invasive disease. Coming towards the pathogenesis, it is an allergic reaction in case of allergic fungal sinusitis or fungus buildup in case of mycetoma. In the invasive type, there is blood vessels destruction, bone destruction, mainly in the acute fulminant and chronic invasive subtype, or there can be type 4 hypersensitivity reaction in case of granulomatous invasive disease. Now, point number 10, what are the radiological investigations? Basically, we do plain CT scan for the initial diagnosis, which can identify AFS as metal dense contents and mycetoma in the form of hyperdense mass. In the invasive sinusitis, there is bone erosion and extension into the soft tissue. So, MRI is used as a complementary tool performed to evaluate extension, which can be checked by a plain MRI. And to see the necrosis, we have to use the MRI with contrast. Point number 11, histopathology. The fungal hyphae invade the mucosa in the invasive form, but not in the case of non-invasive disease. The hyphae are non-septate in mucormycosis, while septate in aspergillosis. Now, coming towards the treatment, all types of fungal sinusitis, they need a combination therapy of surgery, steroid, and antifungal drugs. The duration of oral or parenteral antifungal therapy is very variable depending upon the drug used, the clinical response, and the radiological evaluation before and after starting the treatment and completing the treatment. The steroids, they are mainly used for the allergic variety. Amphotericin B is a macrocyclic choline macrolide antibiotic. The second group of antifungal drugs is triazoles, which mainly contains itraconazole and voriconazole. Itraconazole is recommended in non-invasive type, while voriconazole is used in the invasive type. Amphotericin is the drug of choice in mucormycosis, while voriconazole is recommended for aspergillus invasive infections. Now, comparing itraconazole and voriconazole, itraconazole is better tolerated, while voriconazole is a broad spectrum antifungal drug. Coming towards the side effects, amphotericin is nephrotoxic, while triazoles are hepatotoxic. So, while choosing the antifungal drug, we have to check the renal and hepatic status of the patient. Drug resistance is another important thing. So, it is developing to Aspergillus fumigatus variety. So, we have to use amphotericin B in most of the cases, considering this aspect. Now, these were the 20 points which we will now apply in the next table to understand the disease properly. Coming towards the second step, now we will be applying those 20 key points on this table to understand the different types and subtypes in a better manner. You can see the red headings. This is the disease, pathogens, pathology, immune status, clinical features, mode of spread, investigation, and the treatment modalities. If you look vertically, these are the classification with subclassifications of non-invasive disease, invasive disease, with subclassification of the three variety. So, disease non-invasive, infection limited to nose and sinuses, plain CT sufficient, and hyphae not invading mucosa, and they are septate in all. So, pathogens in the first subtype, all types of aspergillus are involved in this etiology. In case of mycetoma, it is the Niger variety, the black variety of aspergillus. In acute fulminant, the most common group of organisms belong to the group Mucorales, which contain Rhizopus and Zygomycetes. The second variety of the pathogenic organism belongs to the Aspergillus group of the Fumigatus variety. The same Aspergillus fumigatus, that is the causative agent in chronic invasive subtype of invasive disease. And lastly, the flavus variety of Aspergillus is encountered in chronic granulomatous invasive disease. Pathology in allergic, so it is allergic reaction type 1 to all type of fungi. In mycetoma, there is fungus buildup. In acute fulminant, there is blood vessel destruction leading to necrosis. Similarly, in the chronic invasive disease, again there is blood vessel and bone destruction. And lastly, in the granulomatous subtype, there is immune response to fungi, which is type 4 hypersensitivity reaction. Immune status, allergic and mycetoma immunocompetent. Coming towards the acute fulminant type, it infects the immunocompromised individuals. Zygomocytes, they are found in the diabetics, while Aspergillus fumigatus in the neutropenic patients. In chronic invasive type, the guy can be either immunocompromised or immunocompetent, and granulomatous disease is seen in the immunocompetent people. Now, coming towards the clinical features, allergic disease will present itself as nasal polypi. Mycetoma will involve the maxillary sinus. In case of acute fulminant and chronic invasive, the disease arises from the ethmoidal paranasal sinuses and they extend to the orbit and the cranial cavity. The same goes for the granulomatous invasive variety. The mode of spread, allergic and mycetoma, along with lastly granulomatous, these three varieties, although belonging to two different groups, they spread directly. While acute fulminant and chronic invasive both invade the vessels and cause bone destruction. On CT-MRI, there is focal bone erosion in sinus wall expansion in these two varieties, while there is extra sinus involvement in all the three varieties of the invasive type. So, this is the radiological diagnosis of the disease. Surgery, depending upon the type and extent of the disease, can be debridement, FES. So, the nature and the extent of disease would tailor or surgery. So, what are the medicinal treatment used? Now, the use of steroid, it is just limited in the case of allergic fungal sinusitis. The role of antifungals, that is debatable. In case of mycetoma, itraconazole, it is given 100 to 200 milligram twice daily. The duration depends upon the response of the patient and the radiological evaluation. The dosage of steroids which is given is prednisolone 0.5 to 1 milligram per kilogram body weight daily for 2 to 3 weeks. Mind it that the daily dose should not exceed 60 milligram. Now coming towards the treatment, the medicinal treatment of the invasive type. So amphotericin is the drug of choice in case of acute fulminant disease. Now how to remember the dosage? Remember the figure 5. So the dosage is 5 milligram per kilogram body weight for 5 weeks. This can be variable, but I've just given it in a way so that you can remember it easily. Voriconazole can be used as a second line therapy in case of acute fulminant sinusitis. Now, coming towards the last two subtypes of invasive type, voriconazole is considered to be of superior efficacy for aspergillosis. The dosage regime for voriconazole, we give a loading dose of 400 milligram twice daily for 1 day and then start the maintenance dose 200 milligram twice daily till 1 week after being symptom free. Thank you very much for your patient listening.